Hello and good evening, everyone, and welcome to another episode for our live CPD series in DOPS. And I'm very pleased to have with me today my friends and colleagues, consultant cardiologist Dr. Betty Tay and Dr. Ahmad Nizar. And the topic of today's live CPD is Arrhythmias, workshop for GPs. And for me also, I think it'll be a learning session for having neglected ECGs for a long time. Okay, so before I hand over the microphone to Betty and Nizar, I will just take you through some housekeeping slides. So for those of you who've attended our previous sessions, I think you know the drill. Basically, we are going to use Slido for interactive discussion, Q&A. The Q&A will be left for the end of the session. But if you have Slido app on your mobile, you can enter the code V811 and that will take you to the Slido session, or you can scan with your mobile's QR code scanner and that will take you to the Slido website with the at the event for this evening's talk. Okay, so we're going to use Slido. It's also embedded in the CPD stream page, so you don't have to do anything. It's there. All right. When you ask questions, please also put in your real name so we can address you rather than being an anonymous person. All right. So that's the Q&A, which we'll use at the end of the talk. I think most of you know how to claim points. The points will be claimed by scanning the QR code for the event at the end of the talk. So use your MMA app and you click at the upper left of the QR code there. There's a scan QR, and that's where you scan the QR code displayed for at the end of the talk, and you'll get a point instantly. Okay, and I'll display the QR code here. All right. This module will be available offline later. So for those of you who did not catch this live, you can get points by answering MCQs after watching it. And it's available in the bulletin board in the CME section. Okay. All right. So without further ado, I'm going to switch over to Betty's slides, and I'm going to hand over to Betty and Ahmad Nizar. So carry on, guys. Okay.
Hi, good evening, everybody. Thank you for having us. Welcome to the workshop. I have to say that this workshop is actually made possible because of sponsorship from Medtronics. And we would like to start with the first slide. So during this, during this workshop, we would like you to know how to read ECG. It can be very intimidating reading ECGs, but if you know the pathophysiology of how the electrical impulse is generated, then it will make it very easy for you to read ECG. And then Nizar and I will speak on atrial fibrillation because it is the commonest atrial arrhythmia. And then how do we treat arrhythmia, especially in your setup in a general clinic. And then we talk about the new frontier of pacemaker. Okay. The cardiac electrical system controls all events that occur when our heart pumps. Now the SA node is located within the wall of the right atrium. The SA node generally generates the electrical impulse in all cases that is then carried to the AV node by the special conducting tissue. Upon reaching the AV node, the electrical impulse is then relayed down to the bundle of His. The electrical impulse generated by the SA node causes the right and left atrium contract, and depolarization of the ventricle happens shortly after. Now, this is actually a picture which actually depicts where the SA node is, and following which, let me just get my pointer. So this is where the SA node is, and then it will generate the electrical impulse coming to the AV node, and then transmitted to the bundle of His. Now this is the normal ECG. The P wave is generated when the SA node generates an electrical impulse, and then the QRS is when there is a ventricular contraction. Anything you like to add at this point of time, Nizar?
Well, I think the PQRS denotes the atrial activity is from the P to the Q of the ECG. That's when the atrium depolarizes. And then the QRS complex is actually when the impulse travels through the His bundle as well as the Purkinje system of the ventricle.
Okay. So now that we know what the normal ECG looks like, okay, we then divide the arrhythmias into 4 groups of arrhythmias. Okay, we have basically extra bits where you can have premature atrial, ventricular, or junctional contraction. We see this very often. We can have supraventricular tachycardia, such as atrial fibrillation, atrial flutter, or SVTs. We can have ventricular tachycardia, which is ventricular tachycardia and ventricular fibrillation. And of course, on the other end of the spectrum, we have bradyarrhythmias, which includes sick sinus syndrome and heart blocks. Now, in atrial arrhythmias, we have atrial tachycardia, atrial fibrillation, atrial flutter, AV nodal re-entry tachycardia, and AV re-entry tachycardia. Maybe Nizar would like to explain slightly more, or should we just go on with until we come to
we reach the ECGs, then
yeah, that's fine.
Yeah.
Okay, so this is atrial tachycardia. Okay, why is it atrial tachycardia? It's tachycardia because it's more than 100 beats per minute. But if you can see here, the P wave is not exactly a P wave. It's inverted. So the pacemaker here is actually the atrium. So this is how you look at it. So when you look at an ECG, you look at the morphology of the ECG, you look at the rate, and you look at the rhythm. Okay, so the rate is faster, and then the rhythm is regular, but of course then you look at the morphology of the P wave and it's inverted. Therefore, it is not generated by the sinus node as a pacemaker. Okay, again, if you look at the ECG, you look at the rate, the rhythm, and the morphology, you can see here that this is irregularly irregular. Okay, it is fast, okay, and this is what we call atrial fibrillation. This again is the most common finding in patients with arrhythmias, okay, and we will discuss this further as we go along. Atrial flutter is where you see this sawtooth kind of appearance, and it can be regular or it can be irregular, and it's usually regular if it's just atrial flutter, but if it's atrial flutter, atrial fib occurring together, then it is not regular. Okay, and SVT is usually regular. I mean, it is always regular. It is very fast. Sometimes can occur up to 200 beats per minute. Okay, so this is an SVT. It is narrow complex. It is fast. Okay, and you don't see any P waves. Okay. Nizar, you like to comment on this?
Okay. With regards to SVTs, SVTs are tachycardias that have narrow QRS complex. And there are two main, well, if you consider all atrial tachycardias, they're all with narrow complex QRS as well. So a broad division of patients with tachycardia can be either narrow complex or broad complex tachycardias. Generally, narrow complex tachycardia denotes supraventricular tachycardias, and broad complex tachycardia generally means ventricular tachycardia. Okay, so the common cause of supraventricular tachycardias are the AV nodal reentry tachycardias and the AV reentry tachycardias. Now, with AV nodal reentry tachycardias in sinus rhythm, you will see normal ECGs. But in a proportion of people with AV re-entry tachycardia, you might see this sort of features when they are in sinus rhythm. This is a depiction of what WPW syndrome looks like. You have a shortened PR interval, and you see that the onset of the QRS complex is actually slurred. And this can be either slurred upstroke or a slurred downstroke. And very often, following the QRS complex is repolarization abnormalities that is seen as usually as ST depression. This is not a sign of ischemia. This is repolarization changes that occur because of the unusual way that the ventricle is actually stimulated. So this is Wolff-Parkinson-White syndrome. And they present with supraventricular tachycardias and as well as atrial fibrillation. The big difference between Wolff-Parkinson-White and the other SVT is this is probably the only SVT that is associated with sudden death. And you probably will need to realize that. It is rare, but it is certainly possible to present in cardiac arrest in people with WPW. So with regards to WPW syndrome, I think it should be referred further on for further evaluation. Betty?
Okay. So we look at ventricular tachycardias, and ventricular tachycardias, again, we have something very common, which is ventricular premature contraction. We have accelerated idioventricular rhythm. And of course, on the other the other spectrum of the disease, we have ventricular tachycardia and ventricular fibrillation, and we have torsade. Let me just explain to you how ventricular ectopics may look like. This, okay, is a ventricular ectopics. You can see that these are normal rhythms and followed by another ventricular ectopic, and this looks different from the one that was previously shown where the arrow is showing. This is actually a multifocal ventricular ectopic, so it is more worrying than just your usual ventricular ectopics that you see. And of course, if you see a broad complex tachycardia, the first thing that should come to mind is ventricular tachycardia, and this should be diagnosed as VT until proven otherwise. So, and of course, this is ventricular fibrillation, but you don't see a proper pattern at all. The blood pressure should not be able to be recorded. Patient should be it's almost as good as an asystole, but it is easier to treat because if you defib the patient, especially if the patient is coming in with an MI, you can actually save the patient. And then we have bradyarrhythmia, which is a first-degree heart block, where the manifestation of it is usually on ECG. Patients will not have any symptoms, and it's just shown to have prolonged PR interval. Then there's second-degree heart block, and then there's third-degree heart block. Okay, this is sick sinus syndrome. Nizar?
Right, sick sinus syndrome is a bradyarrhythmia, but it's not AV conduction abnormality. With sick sinus syndrome, there are various types of presentation, and this is one of the ways that they present. That is the failure of the sinus node to fire, and you see periods where there is absence of P waves completely, and at other times you see P waves followed by QRS complexes. So this is a condition that we call as sinoatrial pauses, and these pauses are prolonged, and very often these patients will present with syncope. On the other hand, they can also present with tachycardias at the same time. Usually it is atrial fibrillation. And when the atrial fibrillation ends suddenly, the sinus node is already weakened. And what results is actually this prolonged pauses, and they will usually faint. So the sick sinus syndrome can present with just simply bradycardia, or another form of presentation is tachybrady syndrome. And there are other variations and other combinations that they can present with. Betty?
Yeah, this is a second degree heart block. Maybe you can explain to them how it looks like,
Okay.
where the PR prolongation of the progressive prolongation of PR interval. Let me
Right.
just put the pointer there.
Okay. If you think about heart blocks as the type 1, type 2, and type 3, it is an escalating degree of blocks, right? So initially there is conduction delay, that is the type 1, but
From here,
in type 2 AV block, there are two types, type 1 and type 2. In type 1, you notice that there is progressive prolongation of the PR interval
sorry,
before a beat is dropped.
sorry.
Right.
Hold on. Huh? Okay, that's what I'm back. Okay.
Yeah. So you see that the initial PR interval is short, and then the second is longer, the third is longer still, before the fourth is actually dropped. So there is progressive AV conduction delay actually in MOBITZ type 1. In MOBITZ type 2, there is no delay. It generally can progress to a block or a block beat that is sudden. So when you talk about type 1 and MOBITZ type 2, the MOBITZ type 1 AV block is usually, the problem is in the AV node. And with AV node, it's usually an intrinsic problem. So and they are generally not necessary that to be treated. It can be due to high vagal tone in young people as well, or in athletes. But in MOBITZ type 2 block, the block is usually below the AV node, which is at the His or the His-Purkinje system. And they have a greater tendency to progressing to complete heart block. So the MOBITZ type 2 is something that you need to catch and to refer for further treatment. When you have complete heart block, the upper chamber, the atrium, and the ventricle will be beating at its own rates. So you will see no association between the P and the QRS. In this particular example, you notice that the QRS complexes are still narrow. It suggests that the escape rhythm is probably in the His bundle. And when they have an escape bundle from the His, they're usually quite reliable. But if you see a QRS complex that is broad and the rate is very slow, these are usually not a stable rhythm, and they should be referred to the hospital as quickly as possible. Betty.
Okay. We go back to atrial fibrillation, as we know that atrial fibrillation is the commonest cause of arrhythmia. We see it very often in patients with underlying diseases like hypertension, diabetes, heart failure, coronary artery disease, or even aging. But we also see in patients who have nothing at all, and we can call it lone atrial fibrillation. And sometimes they come in with palpitation most times. And what you see on ECG is an irregular rhythm, fast, okay, and it can be divided into paroxysmal, persistent, or chronic. And it increases the risk of stroke because it forms in the atrial appendage as the atrial fibrillation duration becomes more and more prolonged. It is also one of the commonest presentation for thyrotoxic patients. Now, how do we treat atrial fibrillation? Now, the duration of atrial fibrillation is very important. The cutoff point of treatment means reverting the patient back to sinus rhythm is 48 hours. So your history has to be very precise. Okay, you need to ask the patient how long have they had this palpitation. You need to be very certain about it. Okay, then following which we need to treat underlying causes, of course, if the blood pressure is not well controlled. Okay? If the patient has underlying coronary artery disease, or of course thyrotoxicosis. Now the decision is between reverting the patient back to sinus rhythm or to control the rate of the atrial fibrillation and allow them to be in atrial fibrillation. And then the other decision is what kind of thrombolysis do we use? Do we use antiplatelet? Do we use warfarin? Or we use a newer generation of anticoagulation? And then Nizar, of course, will explain to you what is atrial ablation. Okay, so now Nizar, maybe we will talk about this reverting and the rate control.
Yeah, this is in when we consider treatment of acute atrial fibrillation. So if particularly if the patient is symptomatic, and they are usually symptomatic when it's acute because the rate can be rapid. If the rate is very fast, if it's above 140 beats per minute, they usually would require admissions for control of heart rate and to see whether we need to revert the AF as soon as possible. But the decision to actually cardiovert them, whether it's electrically or pharmacologically, will depend on how long the atrial fibrillation has been present. If it's more than 48 hours, as Dr. Betty mentioned, then the chances that you may develop blood clots in the left atrium as a result of stasis is higher. And when you revert them to sinus rhythm, you may cause this blood clot to thromboembolize and cause stroke. So you would want to try, and in that situation, when it's beyond 48 hours, you probably will want to try and rate control them and start them on anticoagulation for at least 3 weeks before we consider reverting them to sinus rhythm. Right? Now,
what are the, sorry, okay, so for rate control, of course, you can use your beta blocker. Usually I would use a beta blocker. Sometimes I would add a digoxin if it's not well controlled. I seldom use Corolan in atrial fibrillation if the patient does not have heart failure. In actual fact, Corolan is not indicated in patients who has no underlying poor LV function, right?
right.
Yeah, I think there's an increased risk.
Antiplatelet, antiplatelets is probably not useful in people with atrial fibrillation. It probably doesn't reduce the risk of stroke. And in combination, dual antiplatelet therapy, when you compare that to warfarin is still superior.
Even in a good LV function patient?
Yep, it's probably not. And the risk of bleeding is probably equal to that of anticoagulation as well. So I wouldn't actually consider antiplatelet as something to reduce the risk of stroke. But you have warfarin and the new oral anticoagulants or the direct oral anticoagulants, such as dabigatran, apixaban, and rivaroxaban. These are the new agents. The big advantage of the new agent is the risk of intracranial hemorrhage is much, much lower compared to warfarin. Before, we always thought that the risk of bleeding is always going to be increased with the anticoagulation. But when we have the trials comparing the newer oral anticoagulant against warfarin, the incidence of intracranial bleeding is much lower with the newer agent. So that's a big advantage. The other is actually you don't have to do regular testing because this newer oral anticoagulant have a wide therapeutic window compared to warfarin, which has a very narrow window. So our choice is always to try and start DOACs rather than warfarin. But as a caveat,
I don't want to. Sorry, I have to stop you here because I don't want to take home message for GPs that they should not start on antiplatelet and there is no benefit in patients with atrial fibrillation and the reduction of stroke. I still believe that the antiplatelet, if you do not know, if you do not know the patient's LV function and you presume it's normal, I think in your clinic it is safe to start on antiplatelet. And I think that you should start on antiplatelet. There are benefits with antiplatelet. Maybe not as much as warfarin, but of course warfarin has a disadvantage of increased bleed. Now, if the LV function is less than 40, there is no doubt, of course, you can either choose warfarin or the newer agent of anticoagulation. But in a normal patient with a normal LV function, I still think that antiplatelet plays a very important role.
Yep. your choice of starting anticoagulation should be based on certain factors. And there is a score or a score that we refer to. It's called the Chat-Vest score. And the risk of stroke is present when a person is above the age of 65. Younger patients without any other risk factors, and which includes heart failure, impaired LV function, a previous history of stroke, vascular disease, either peripheral or coronary. The age, there's two ages, more than 65 and more than 70. And then gender, women are at a higher risk, as well as diabetes and hypertension. So if you are a woman that is less than the age of 65, you do not need to start them on anticoagulation. Now, if you have a woman who has high blood pressure, even if they're less than 65, there's two risk factors there, you should consider them on anticoagulation. So you refer to what we call the Chat-Vest score before you want to start a person on anticoagulation.
So means that your threshold to start on a newer on an anticoagulation shouldn't be very high. That's what we want to say. So you should always consider starting the patient on this newer anticoagulation, because it is safe, it is easy to manage, and you don't have to worry about repeated INRs. So it is very, very easy for the general practitioner to actually start them. Let's go on to AF ablation briefly. Okay, hold on. Let me just change the slide.
Okay. There are three categories of patient that you would consider AF ablation. They would be young patients who are facing the chance that they may need anti-arrhythmic therapy for the rest of their lives. You should consider RF ablation or ablation in that situation. Number two is in those patients who are symptomatic and who are not well controlled on their anti-arrhythmic drugs. And number three is usually in patients who request them. Now, it would be unusual, you think, how do you get rid of atrial fibrillation? Because we were taught that atrial fibrillation involves the whole atrium, which is chaotic. So what do we ablate? Well, in truth, atrial fibrillation, there are two main factors that propagate atrial fibrillation. What triggers it is actually a focus of a rapid firing focus that usually are within the pulmonary veins. So you see here the balloon abutting against the left superior pulmonary vein. So what we do then would be to try and target the pulmonary vein itself so that we corral this focus and stop it from actually influencing the atrium and triggering atrial fibrillation. The other factor is actually the disease in the left or the right atrium that actually perpetuate the atrial fibrillation. If you have a normal atrium, you cannot actually sustain atrial fibrillation. So the greater the degree of scarring in the atrium, the greater the chance that you can develop atrial fibrillation, right? And so much so that if the degree of scarring in the chamber in the left atrium is very florid, even radiofrequency ablation or a cryoablation will not be successful in trying to maintain normal rhythm. So this is an example of a cryoablation. What we use is actually liquid nitrogen. So the front portion of the balloon, which is abutting against the antrum of the pulmonary vein, is actually frozen. They're actually frozen because the liquid nitrogen is very cold. You can achieve a temperature of minus 60 degrees or not less than minus 60 degrees. And you will cause scarring to occur around the antrum of the pulmonary vein. And this scarring is what isolates the pulmonary vein.
What's the success rate for this?
It's usually close to probably closer to 80 to 90% actually.
Okay, and how much would it cost?
It is expensive.
Okay.
It is very expensive. Yeah.
But it is a treatment option, a cure, right?
Potentially, you can achieve a cure. But like I said, there are two factors that you're dealing with, and we are dealing with one of the factors here. So the degree of scarring in the left atrium will also determine whether recurrence is chances are high. So the younger the person, the more likelihood that they can achieve a cure. That's why we prefer to treat the younger patient with paroxysmal atrial fibrillation with this method actually.
Okay. So now we talk about treatment as SVT, and of course, we talk about because this is a workshop for GPs, and we need you to handle patients with SVT. One thing to remember is patients, even though they complain of palpitation, they usually tolerate the SVT very well. Hemodynamically, they are very stable. So think of simple things like carotid massage, Valsalva maneuver, before you go into IV adenosine or verapamil. There is a cure, of course, for SVT, and I think the success rate with radio frequency ablation is very high. The other option is, of course, daily verapamil, which can be cumbersome and sometimes not the appropriate treatment for patients. What do you think, Nizar?
Yeah, quite typically, the patients who present with SVT are women. The majority of cases of AV nodal reentry, more than 70% are women. And they tend to occur in women of childbearing age. So if their episodes of SVT are very frequent, it can be troubling during pregnancy, or it can be made worse by pregnancy itself. So in that situation, I usually would consider catheter ablation if their episodes of SVT is more than 3 to 4 times a year. And that would be actually quite debilitating. And you will need to take your verapamil or any of the antiarrhythmic drugs daily to prevent an episode. In that situation, I would consider them, or you should refer them for radiofrequency ablation. Radiofrequency ablation
go on, Ahmad, go on.
for SVT has actually a very high cure rates. This is usually above 95%. And there are risks of complications, but they are related to where the source of the SVT is. If it's an accessory pathway that occurs close to the AV node, then there is a risk for AV block. But it would still be less than 0.5%. The risk is of complete heart block. If you have AV nodal reentry, the risk is a little bit higher. It's usually 0.5 to 1.5%. But if the person is actually very symptomatic with frequent episodes, I would still consider RFA as the choice of treatment actually.
Okay, how about Valsalva maneuver? Can you explain to us?
Okay.
I'm going to explain to you how you're going to do Valsalva maneuver. Basically, from what I usually teach the patient is that you close your nose, your mouth, and you try to blow it out your ear. What do you tell your patients?
Well, there is something called the modified Valsalva maneuver, which appears to have a much higher conversion rate for SVT. So what you do is you sit the patient up and you ask them to take a deep breath and probably either blow into a small balloon or the end of the syringe, right? Try and make them blow the plunger of the syringe, a plastic syringe. You don't have to give them a glass syringe. So they attempt to blow the plunger to push out the plunger from the syringe, and make them do that for about 30 seconds or so. And then what you do is you put their head down flat and raise their legs up for about 15 seconds. before you sit them up again. Doing this sort of Valsalva maneuver, there is probably a 40% chance that you may terminate the SVT compared to a much lower when you do the traditional Valsalva maneuver. So that's a modified Valsalva maneuver.
That's a good idea. I've never tried that method before. Okay, hold on. Let me just go back to the slides. Okay. Now, of course, treatment of VT or VF is a medical emergency. It is not easy in a GP setup. Okay, basic CPR is needed. If you have automatic external defibrillator, that would be best. The drugs that we use are lignocaine and myodrone and beta blockers. Beta blockers in a long term, not in an acute setting. And of course, to treat the underlying cause. Usually VT or VF is one of the main cause is actually poor LV function or patients with acute myocardial infarction. But in the long run, there is always, of course, ablation for VT and, of course, an implantable ICD. Okay, we go back and elaborate on this first, Nizar.
Yeah, if you see a broad complex tachycardia, you should treat this with urgency. I would suggest that if you see someone in practice, in clinic practice, what you should do is probably call an ambulance to fetch them to go to a hospital, and try and ensure that the ambulance is equipped with an AED so that they can be defibrillated. It is unlikely that the problem with ventricular tachycardia is they can deteriorate to ventricular fibrillation, and you need to watch them closely, right? I don't actually suggest drugs as an outpatient clinic or a GP clinic.
Yeah, it's very difficult.
Yeah. So you need to treat them with urgency and get them to a hospital in an ambulance which is equipped with the defibrillator, if possible.
Okay. We will. Oh, okay. Hold on. Let me go back because So the treatment of bradyarrhythmias, of course, many bradyarrhythmias like first degree heart block and MOBITZ type 1 will not need treatment. If you have sinus bradycardia, again, we can use IV atropine. I'm not sure how comfortable you are using IV atropine in your clinic setup. Usually, sinus bradycardia is associated with inferior MI if they are not due to aging. Acute bradyarrhythmias needs temporary pacing, and in long term, they will need permanent pacing. So this is what a transcutaneous pacing looks like. Basically, for transfer of patients or while waiting for the cath lab to be activated, it is like the defibrillator comes in the same machine. We can actually put the pad on and then they will generate impulse. It can be very uncomfortable for the patient because it is like externally being shocked. Now this is a temporary wire. Okay, of course, we usually do it transfemoral, and we put the catheter into the right ventricle, and then we pace it. And this is a lot more tolerable, and it is on demand. So once the patient's heart rate goes above, let's say 60, then the pacemaker will, this pacing wire will then, once it is below 60, then the pacemaker wire will then generate impulse. But what is a permanent pacemaker, Nizar?
A permanent pacemaker is implanted. So you have leads that are usually introduced through the subclavian vein, and it travels through the nominate and the supraventricular, vena cava into the right atrium and into the ventricle. You have several types of this. You either have a single chamber pacemaker or a dual chamber pacemaker. But a pacemaker system, like any chain, the weakest link is actually it can actually be troubled by the weakest link. So in a pacemaker system, you have the generator, which is the device that we place at the left shoulder usually. That's connected to the lead, and that is actually implanted in the heart. So you have three components of this: the generator, the lead, as well as the person's heart. So usually it's the lead that is the weakest point, and that is an issue that can be overcome by this new type of pacemaker. The other issue with the pacemakers generally is actually next. You can show the next slide, Betty.
Yeah.
You need to make an incision to place the generator into the pocket, and sometimes this pocket can get infected, and so that is the other weak link of this type of pacemakers. So there is a new type of pacemaker that is available, and it's called a leadless pacemaker, or Medtronic calls them MICRA. This is currently probably the smallest pacemaker in the world, and it's probably just slightly bigger than the size of your small finger, and the tip of your small finger actually. It's inserted percutaneously through the inferior vena cava, so from the femoral vein, and it's actually minimal invasive. So there's no scar that is made in the shoulder itself. And because you take away the lead, there is less component to this pacemaker. It is just this bullet-like device that is directly in touch with the heart.
Maybe I'll show the video and see.
Yeah, you might as well. Yeah. It shows how this is introduced. So that is the pacemaker. And these are the devices that we use to introduce the pacemaker into the patient. There is a long sheath, and this sheath is actually introduced through the femoral vein. First, we need an access to the femoral vein, and we use a guide wire that we push, a long guide wire that goes right up into the right atrium. And over this wire, we then push the sheath through a technique called the Seldinger technique. And this is guided by the guide wire. And once we reach the right atrium, the dilator is removed. So now we have access direct into the right atrium. And we introduce this delivery device that has got the pacemaker at its tip. Now, the device is then introduced under fluoroscopic guidance. You can see that it is against the wall, and we want to be at probably on the septum, not exactly at the apex. And you see there is a knob there that we use to deliver the device. At this juncture, the device is still attached to the delivery system by strings. And the intracardiac image shows you the device being deployed. It's got hooks at its tip, and that hook will be embedded into the myocardium. And you can then check to see how well it is embedded by pulling on the strings at the back. And once you are happy with the position, you can check the parameters that is of the implant. And if it's satisfactory, then we can release the device by cutting the strings attached to it and pulling the strings off. And the pacemaker now is actually deployed. And you have a device that is directly in the heart chamber itself, and therefore you have less links, weak links to the system. The device can last up to 10 years. And if when the time comes for a new replacement, you put in a new device. That's all.
Yeah. I think we end the talk with this video, and yeah, Alan.
Well, I'm back. Fascinating talk, guys. I learned a little bit. So I'm sure there are questions. This now is the time to ask. So we'll start because we want to use Slido as the discussion site. So what I'll do is share the Slido screen. Okay, then we'll take the questions there. I think there was a question first from Dr. Varan, and the question is, in ED, when an unstable patient with ECG, difficult to differentiate between SVT with aberrancy versus VT. Can we presume VT and treat, or must we use the Brugada criteria and confirm? This one you guys have to answer. No idea what Brugada is.
I
Okay.
suggest that any broad complex tachycardia should be presumed VT. This, semantics of trying to differentiate SVT with aberrancy and VT should be left to be in hospital rather than outpatients. So any broad complex tachycardia, it is safe to assume that it is VT and to treat as such. Because
But he did say it's in ED. So in ED, I guess it's in a hospital.
Right.
It is very, very difficult to differentiate. For me, if I do not know the patient beforehand, I do not have an existing ECG that has been documented before, I would treat it as VT until proven otherwise. Maybe sometimes if the patient is very, very stable, I would give some a small dose of adenosine. It all depends, but I would treat it as VT until.
How would it be treated? Did it depend whether they are hemodynamically stable or not, or
True.
Or is it medically or cardioversion? Just out of curiosity.
If they're stable, yes, go on, Nizar.
If they are stable, you can consider anti-arrhythmic drugs. But I would suggest that that should be in intensive care or the chronic care units rather than the ED itself. So if they become unstable after we start anti-arrhythmic drugs, we can still cardiovert them. And I'd suggest with cardioversion as well, they should be sedated before you do it. So they should be prepared. Right.
I mean, even as a cardiologist, I do not like to see broad complex tachycardia. Truly.
Okay.
Okay, any more questions?
Jayanti has a question. How long can an elderly patient, 78 years old, be kept on double antiplatelet therapy? I don't think it's exactly related to arrhythmia, but just a question on antiplatelet. As many...
No. I think she's talking about antiplatelet therapy in atrial fibrillation, Ellen.
Oh, okay. As many geriatricians are not in favor of keeping them on long-term therapy. Okay, go ahead.
Okay. I find that the geriatrician and the cardiologist are two different species of people. They tend to be very conservative. And I think that in atrial fibrillation, of course, Nizar said that he prefers the new generation of antiplatelet. But if it's more than 78 years old, I think that I would put the patient on just antiplatelet if the LV function is normal. What do you think, Nizar?
Well, the issue is this. The greater the patient's age, the higher the risk for stroke. So by the time you reach 80, your risk for stroke is probably in double digits. It's going to be between 12 to 14, 15%, if that is the only criteria of risk you have, that is age. You have an additional, say, hypertension, it may reach even up to 20%. So they generally would need something to protect them against stroke. If you're considering any patients above the age of 80, or some people would say 75, then you can use a reduced dose of the new oral anticoagulants. So for example, apixaban, they suggest 2.5 milligrams PD. With dabigatran, it's 125, rather than the 110 rather than 150. And rivaroxaban, it's 15 milligrams daily. So reduced dose is one option. There is another option in people with very high risk of bleeding. And this is actually a device that is known as the left atrial appendage occluders. They are used to actually plug up the left atrial appendage, where 90% of thrombus occurs anyway. So if you actually use this device, you can go off anticoagulants completely. And the risk of stroke is probably equivalent to using warfarin. So that is the option that you have.
I think as a doctor, you need to have a little bit of courage to actually treat your patients. So I would think that you should consider anticoagulation in patients who are old with atrial fibrillation, especially if they have valvular heart disease or they have poor LV function. Definitely. It
Okay,
is
can I
only
ask something?
Yeah, sure.
Yeah.
Nizar mentioned the chat to VAS score in the side when we were talking about whom to anticoagulate. On the other side, if you're trying to assess bleeding risk, I'm aware of something called the Hasbled score,
Correct.
which
yes.
assess bleeding risk. So would that be useful in your practice to decide who, in the elderly especially, if they have high Hasbled score and high bleeding risk, maybe those are the patients you want to avoid anticoagulation? Is that
That
useful
is
score
true.
for you?
Yeah. If your Hasbled score is more than 5, then obviously that appears. I mean, most people would concur that the risk of bleeding is high. In those situations, whom you consider the risk of stroke is also very high, and that is where the atrial appendage occluder or plication of the left atrial appendage may be an option actually.
I had a nightmare of a patient with myelodysplastic syndrome, progressing into acute myeloid leukemia, and she was old. She was in her 70s, and she also had proximal atrial fibrillation. So, and she had falls.
Oh,
You know how
yes.
problematic falls, low
That's
platelet,
true.
AML, and she had proximal AF. But she managed
It's
to go
like
into remission with treatment. So during the remission period, what's the best way to treat an AF? And actually, she went up and down with cardiologists and said, whether to put in the Watchman device or whether to go on with a NOAC for a while. So while during that time she was in remission, she actually went on a NOAC for a while. They opted not for. Unfortunately, after a few years, she relapsed. So then you had to take off the anticoagulation. It's a real nightmare.
Yeah.
Low platelets.
Nightmare within a nightmare. Nightmare within a nightmare.
But the Watchman
the Watchman is an option, obviously. But the NOACs is not too bad either. The NOACs have actually the risk of bleeding generally would be GIT, isn't it? And that should still be manageable. The risk of intracranial bleed is very low. It's usually quoted as less than 0.8%. So, which is comparative to, say, warfarin, which is about 1.5%. That's significant. So if you consider bleeding in the GIT as a risk, but that's probably treatable actually, rather than
in
having
the GP setting, just from the hematologist point of view, if we ever consider NOACs in the elderly, just really pay attention to the creatinine clearance, not just the creatinine, the GFR, very, very important. Otherwise, they are high risk of bleeding if you overdose them. Yeah.
Okay,
Particularly if you're
I
thinking
just need to say this before anything else. We are all talking about atrial fibrillation that is non-valvular. Okay, remember this. Maybe we forgot to mention it, but the treatment that we are now discussing is all in patients who had no valvular heart disease. Okay, so if it's a valvular heart disease, then the newer generation of anticoagulation should not be considered.
Can we move on to the next question,
Yeah,
which
that's
is
right.
from Dr. Shafiq, who's asked, how common is atrial fibrillation caused by ACS, acute coronary syndrome?
Not to say very common. I don't think it is one of the presentation. Usually ACS will present with chest pain. But in the long term, chronic disease always cause atrial fibrillation? Nizar?
I think AF that complicates ACS usually would suggest that the let's say myocardial infarction is usually quite large, and it's a marker for poorer outcome actually. So we don't see it frequently, especially these days when we actually do primary PCI. They're less likely to present as atrial fibrillation.
Okay. There's another question from Jayanti, and she asked, she has an elder 70-year-old patient who had his pacemaker giving him shock-like symptoms and lethargy. So what can they do in the periphery away from Serdang Center? I guess that's where he was treated initially.
Nizar, maybe Nizar would like to answer this.
Okay, this is unusual.
Yeah, very
you don't
unusual.
get shocks from your pacemaker generally, unless you have a device that has probably got a break in the insulation of the pacemaker, or the contact, the header of the pacemaker is actually loose or something. It's very
Even that also, you seldom get sensation such as a shock-like syndrome.
Yeah.
Lethargy,
the usual
yes.
one that I see, I do have patients who complain of this, but it's usually the scar, the keloid that's giving them that sensation. So the keloid at the scar of the pacemaker may be very sensitive, and when it rubs against the clothing, they may produce this shock-like, sensation. But it doesn't actually come from the pacemaker. It's actually the keloid.
Oh, okay.
Yeah, I don't think I've seen any of patients like this.
Can an echocardiogram detect thrombus in the atrial appendage, the absence of which it would be safe to revert? I guess it means cardiovert even after 48 hours.
Yes. Okay. Yes, you can actually do a esophageal echocardiogram. That would actually see the left atrial appendage very well. And there have been, the guidelines suggest that if you want to cardiovert after 48 hours, and the patient is not on anticoagulation just yet, then there is one option to have a look at the left atrial appendage through TEE.
And maybe ask whether the patient is wearing an Apple Watch. I remember reading a news article. Yeah, some American cardiologist, I remember, was reading in some tech article that they analyzed the patient's rhythm from the Apple Watch over a long period of time, and then they decided it was safe to cardiovert. I don't know whether that's still valid. Did you come across that, Nizar?
Yeah, I guess it can tell you when it starts, the Apple Watch. So it'll give you an idea how long you've had it.
Yeah.
But usually a careful history would also be able to determine when it started, actually.
Yeah. Okay. Is that the cure? Oh no, another person who is so QR code anxious. That's not the QR code for points, please. That's the QR code for the Slido. So hold your horses. We'll come to that. We'll come to that. Questions first. I think there's still some questions. So Dr. Tan asked about MICRA. Is it affected by diathermy? What precautions do we need to take during surgery with diathermy? So Dr. Tan is an anesthetist. Can it be removed if there's a problem?
Okay. It can be removed only within the first few weeks. It gets epithelized very, very quickly. And usually by, say, 8 weeks or so, it becomes almost impossible to remove. It is affected by diathermy, but it has to be direct. So if you, I always suggest that in people who have a pacemaker, if they can use a bipolar diathermy, it's much better. But I hear that the surgeons don't like bipolar diathermy because they have to actually, apply it more frequently. So if you're using a unipolar diathermy, as long as the circuit is away from the heart, it is safe actually. What was the other about the?
Can it be removed if there's a problem?
It can be removed, but only acutely. it can be snared out, but after a certain period, and about 8 weeks or so, you get an epithelium covering it, and it becomes embedded in the wall. So you won't be able to access it by then. So only acutely you can remove it. So obviously the issue with MICRA is always real estate. So in the future, every 10 years, you have to implant a new device. And where do you implant them? And in a young person, it might be an issue. The other is obviously, it's only the ventricle that you can pace, right? So the indication is limited to people with atrial fibrillation or complete heart block. These days, there is a form of MICRA that can sense the atrium and therefore beat sequentially with the atrium and in people with complete heart block, but not with, it doesn't support the atrium at all. So that's the weakness of MICRA.
Thank you, doctors, for this informative session. Thank you, Jayanti. Question from Zal. Which anticoagulation would you recommend for a morbidly obese patient with AF? Weight more than 130 to 140 kilos. Wow.
I think the weight is not a problem. I still would use a newer generation of anticoagulation.
Yeah. It's a
So that's
standard dose.
yeah.
With the newer anticoagulation is a standard dose. It doesn't take into consideration the weight at all.
So,
can you comment on AF in thyrotoxicosis?
Okay.
okay. Atrial fibrillation in thyrotoxicosis is fairly common, especially in the acute stage where you have not treated the thyroid. And it can be, sometimes I do try to cardiovert patients when they actually have been treated for thyrotoxicosis, means I would anticoagulate them for a period of time and then wait for the thyroid function to normalize. And then if the LA and the RA size are normal, then I would cardiovert them and try to maintain them sinus rhythm. Nizar?
Well, thyrotoxicosis is a risk factor for thromboembolism as well, and they're common in women. So you need to anticoagulate them. It's not in the CHAD-VASc score, but in a lot of other scores prior to the CHAD-VASc, thyrotoxicosis was one of the factors. So it's not included, but it is a risk factor. It is a reversible cause for atrial fibrillation. So in this situation, when the patient is euthyroid, their thyrotoxicosis is controlled, their AF usually becomes better as well, unless they have a thyrotoxic cardiomyopathy on top of the thyrotoxicosis. Then you have a tendency for the AF to persist, actually. So I don't treat them long term. I usually try and maintain sinus rhythm. Acutely, I usually use a beta blocker to try and reduce, control the rate and reduce the symptoms as well. And propranolol here is particularly useful because it seems to reduce the conversion of T4 to T3, and they tend to be effective as well. So not long term, it's reversible, and that's usually the way that I would treat it. Consider anticoagulation, also not long term until they become euthyroid. For a while after they're euthyroid, I would continue it, maybe up to a year, and then I'll stop.
I hope that answers your question, Dr. Liu. And Marianne Gonzalez asks, do you attempt cardioversion again after the first attempt failed and currently on medication for AF?
I hate cardioversion actually, because patient in AF tend to go back to AF very frequently, and it's very difficult to maintain them in sinus rhythm. So if truly I did attempt to cardiovert a patient that has persistent or chronic atrial fibrillation, not talking about acute atrial fibrillation, of course, I would not attempt anymore after which. Nizar?
I would give every patient in their first episode of atrial fibrillation a chance. So if they persist in atrial fibrillation, I would consider cardioversion. Now, if that first attempt fail, I would usually persist because I've usually prepared them, right? I would go up to the maximum joules actually. up to 150 joules, 120 joules if necessary to get them back to sinus rhythm.
Oh, you mean if you, sorry, is the question about cardioverting the patient electrically and failed, or is she asking whether you have already cardioverted the patient and then the patient came, yes, it recurred. So I'm answering.
You're talking about electrical cardioversion. I am talking about electrical cardioversion as well. But,
yes, but you're talking about the first attempt.
Yeah. So if
first attempt, of course.
I would try and be persistent and try and get them to normal rhythm. Actually, I've had patients who has their first episode, and you'd be surprised. He was not young. He was already 60 plus, and when he was reverted to sinus rhythm, he maintained his sinus rhythm for 2 years. So there are these patients who can sustain normal rhythm. But usually, they will usually require antiarrhythmic drugs for rhythm control as well. Now, if you attempt, let's say, for example, the person has paroxysmal atrial fibrillation, you give them pharmacotherapy to revert them to normal rhythm, and then they recur, whether you should try and attempt to get them back to normal rhythm. If they have paroxysmal atrial fibrillation and they're comfortable when they're in sinus rhythm and symptomatic when they are in AF, I would consider electrical cardioversion actually in these patients as well. These are the patients who, if they're very symptomatic, I would even then push them to do a cryoablation.
I think we've taken about an hour already. Okay. So I think we come to the end of the session. There's one last one, but I think the question is incomplete, so we can't address it. And there are a couple of comments in Facebook, but we asked everybody to comment in Slido. So I'm afraid we can't address those Facebook comments other than say next time, please use Slido. So now comes the moment I think everybody is waiting for, which is the
QR code.
I really like your background. I have a virtual background.
I'm also waiting for the QR code.
Oh, okay. Everybody's going to scan. So am I. Okay. So that's the flyer.
You have enough points.
Yeah, no. It's kiasu. I got to get more. Okay. So this is the QR code for you to scan. Let me get that thing. Let me check. Once again, I hope I got the correct event. Yeah.
Okay, thank you.
Yeah, you may have to refresh it. Sometimes you don't see it. There's a refresh button. So yeah, it's showing up correctly on my app. So don't say there's no point. The point should be instant. So what you need to do in your MMA app, there is a refresh button in the upper right of the QR code here. There's a refresh there. You just hit refresh. Then in your CPD records, you should be able to see the event recorded there at one point instantly. And I keep telling, I'm afraid our current MMA app limitation is you cannot scan and watch with the same device. In the next generation MMA app next year, we hope you can actually take a screenshot, then you load the QR code into the app, and then the app will recognize the QR code without, so you can do it all with the same device, but not at the current moment. The MMA app is undergoing a revamp, and the revamp hopefully will be ready by June next year for the next cycle CPD. There are a lot of things coming up in the MMA app as well. Okay, so thank you guys. It was very informative. I learned a lot.
Okay, good for you.
Everybody found it useful. I think all the things sound vaguely familiar. Sabah maneuver.
From your medical school days, is it?
A few years ago, when I did acute medicine, and I gave IV adenosine. IV adenosine was very scary. I remember when you give IV adenosine, then the patient feels as though his heart has stopped.
Oh
a
no,
long
it's the most rewarding thing to
They
do.
they feel as if they're getting a heart attack because there's a
Yeah.
squeezing sensation in the chest.
But actually, when you look at the ECG, it's very nice because
No, there's a
they
long
revert.
pause. Then
There's a
Oh, not
pause, yeah.
necessary. Not
so during the
necessarily
pause, there's
so.
no heartbeat, and then everybody panics. Patient panics, doctor
The
panics.
physician gets a heart attack.
There's no heartbeat, nothing. Asystole, then it comes back. And then the time the patient feels a bit awkward. I don't know whether they can give it in a GP clinic without ECG
No,
monitor.
I don't suggest it. I really don't suggest.
I think
So
the
maybe just
Valsalva maneuver is what I would do, yeah.
Yes,
but
either a carotid
the
massage.
I learned about the modified Valsalva maneuver, so that's new to me. So yeah, I can try that. I guess they don't do eyeball massage anymore. Eh?
No,
No.
Dislodge the lens.
you can dislodge lenses.
We have it in the next chat when we have a ophthalmologist with us.
Okay.
Okay. I see you guys then.
Okay, so
Right.
thanks very much. We'll end
You're
the
welcome.
stream here. The
Thank
video
you.
will still be there. Either you're watching in our Docs Facebook, or then you can always go back and scan the QR code. It'll probably still be valid for another half an hour, 45 minutes. Please don't go and take screenshot and share around to everybody just to get points. That's only cheating. This is an honest system. So we trust you. You watched it and then you scan it when they actually watched it at the end of it. Okay.
Oh,
We
you
can
mean if
actually.
you take a picture, you can actually share it with others?
I hear there are some people doing that. That's very naughty, but that's
Oh.
not very ethical and actually not meant to be like that. The MMA had put up this system to make it easy for people to get points, but we also trust you that you have genuinely watched it and then scan it at the end. We can
You
also
watch
track.
it anytime.
You can watch it
You can watch it
anytime, but the
Yeah.
code will expire after an hour.
Oh, I
Okay, so if the code has expired, what you need to do is to go to the bulletin board, and then you can go to the CME section. Okay, there's a long link there, but doesn't matter. You just log into the bulletin board, and we'll host this video up later. And together with all our past events, you can do online modules by answering simple MCQs, and you can still get the point. And then what I'll do is probably have reruns over the next coming weeks of past talks as well, and we'll refresh the QR code. So those who haven't attended past talks, they can have a chance again. So once again, I would like to thank Betty and Nizar. Thanks for a great, very informative session on cardiac arrhythmias. Good refresher for me, and I hope for everyone as well. Okay, so good night. And
Okay, see you guys.
yeah,
Good
take
night.
care.
Thank you. Welcome.
Bye, Nizar.
Bye.